I think clarity in 2019 is a little hard to achieve, and I'll explain why it's going to be even harder with a crystal ball for next year. Next slide. Do I have a clicker?
Yeah, here you go.
Yeah, so I am going to, these are my relationships with industry. I am going to talk a little bit about FFRCT by HeartFlow, and they are funding a research trial of mine, so I think that's a relevant conflict. Let's talk about first, what's our problem? You know, what are we trying to address here? Stable chest pain, not the ER patients that Rick talked about, but people who are in the office that say, you know, I've been getting indigestion when I carry groceries or go up a flight of stairs. We all know cardiovascular disease is the #1 killer. It often presents with stable chest pain. It also presents with acute MIs, but stable chest pain. There's actually more than 10 million patients in the United States every year that have this kind of presentation, and of course that involves a lot of testing. What we do know from PROMISE and Scott Hart and other trials is that it's pretty unlikely that these patients have obstructive coronary artery disease and that their outcomes are superb. The CV death MI rate is less than 1% per year. So that's important in terms of test selection, because that has given rise to the question of, are we testing too many people? And of course, there were administrative concerns about over-testing related to growth of nuclear scans, among others. But now we're talking about clinical reasons to suspect that we may be over-testing, because the patients just don't have the disease that we're looking for, and they do it very well. So that's a concern that we need to settle. And of course, the other concern, which is what I think much of what I'll focus on, but I'll talk on both, is that we have many evaluation approaches, all the way from treadmill ECG, which is still done in many practices, through stress echo, stress nuclear, stress MR, CT with FFR, or other functional information, of course, or direct catheterization in the highest risk patients. And our guidelines currently in the US have as the only class 1 indication for a patient with stable chest pain who can exercise and with an interpretable ECG, the only test that's a class 1 is an exercise ECG. Stress echo, stress nuclear are 2A. But this is really different from the UK guidelines, which says you shouldn't be doing stress testing at all in these patients. Everybody should be going to CT unless the risk is greater than 70%, and then you should go direct to cath. So on one side, we have the US saying you should be doing stress ECG, and the UK saying CT. The European guidelines are currently somewhat in the middle. They say you can do either imaging stress testing or CT equal level. So let's look a little bit more about what we mean with the current state. Here's a graphic to help you understand it. With conventional stress testing, even imaging stress testing, 1 in 5 of your chest pain patients will get a wrong diagnosis. And everybody goes, well, no, not in my lab. But that's an 80% sensitivity, 80% sensitivity. And so this is what it plays out to for our patients. Only 1 in 10 will have obstructive coronary disease. Of the 100 chest pain patients, only 5 will require revascularization or be eligible for revascularization. And only 1 of those 99 orange dots will have an event in the next year. And so this puts it in perspective about how low risk this population is. So to summarize what our gaps are, patient selection, we do need a better way to figure out who gets no testing, for whom that's a viable alternative. We need, in those that are testing, we need to understand which test, and we need to know what to do with new technology. So I'm going to address each of these in turn. So the first one is who not to test. Can we identify low-risk patients with coronary disease whom we can follow a deferred testing, watchful waiting, optimal medical therapy? You know, in support of that, of course, as I've said, is the very low event rates and the very infrequent obstructive disease. Also supporting that is the similar outcomes with PCI and medical therapy in a host of trials. Courage is the one we think of, Orbit is more recent. There's no benefit to angioplasty in these patients, by and large, at least in large clinical trials. So why do we need to stress test as a precursor to the cath lab? Why don't we just give them optimal medical therapy? In fact, we know optimal medical therapy saves lives. Statins and aspirin in these patients reduces events. PCI does not, unfortunately, as the data. Against this is our guidelines say that everybody with chest pain needs to be tested. And there's actually no supporting data. There's no randomized trial data, and there's actually no observational data. I've looked really hard to try to find a population of patients presenting with chest pain who were not tested and see what their outcomes are. We just don't have the data in this. And also other logistics things, like we always worry that we're missing left main triple vessel disease, exceedingly rare in these populations, but we worry that we're missing it because we can save lives there. And also it would require revisits for adjustment of medications and a lot of conversation with the patient who comes into the office thinking they're going to get stress tested because the guy across the street got stress tested. And so how do you talk them off of that expectation? But what we really need is a way of identifying these patients. So we took the PROMISE cohort of CT patients, 4,600 of them, and looked at what their findings were. So 27% had completely whistle clean coronary arteries. No little lumpy bumpies, no soft plaque, no calcium. And we said, can we figure out who these patients are, and can we predict, using parameters available in the office at the time of the initial evaluation, who these low-risk patients are? And it turns out we can do that. We're used to predicting high risk. We're predicting low risk. C statistic is respectable. It's not outrageous, 0.73, but it actually improved Framingham risk score. Framingham risk score and Diamond and Forster, and we sent our programming code to Scott Hart. Not only validated it, but they had an increase in the C statistics. So this, I think, is kind of ready for a randomized trial. The next thing is test selection, and there's a number of studies that have come out this year. Pacific trial is one, it's an observational study. It took about 200 patients. The value in this is it took these 200 patients and did everything to them. So every patient had a PET, a SPECT, a CT, an FFR CT, and a cath. So there's no selection bias, there's no population differences. These are all the same patients. And importantly, we have always compared our non-invasive tests, which measure ischemia or hemodynamic significance of lesions, to an anatomic gold standard. And this is just apples and oranges. In this trial, they compared our non-invasive tests to an invasive assessment of pressure drop over a lesion, the invasive FFR CT. So this is now an apples to apples comparison. And lo and behold, the best test was CT with FFR with an AUC of 0.95, which is quite good. Then FFR alone, PET, CT, and down at the bottom was SPECT. So if you want to predict invasive FFR, which has become the gold standard, or IFR, becomes the standard for intervening in the cath lab, CT FFR is going to be your best bet. Scott Hart showed these data. This is 4,000 patients with a 40% reduction in CV death MI and non-fatal MI. Their primary endpoint was about diagnostic thinking, but it's the 5-year data that got everybody's attention, with increased use of preventive care and anti-anginals and no increased use in cath. And so this is hard outcomes data supporting CT. The argument was that the comparator was usual care, which was generally exercise ECG, which is not commonly used in this country, in this population. These are the PROMISE data. Rick showed you the primary endpoint, so I'll skip over that. We actually had a pre-specified secondary endpoint for death or non-fatal MI at 12 months that was significantly reduced in the CT arm, just barely, but it was significantly reduced. So depending upon how you look at your endpoints, there are some indications in PROMISE that there is actually an outcomes benefit to CT. There you go. We also looked at the highest risk group in PROMISE. This came out earlier this year in JACC, our diabetics. No surprise, the diabetics had more risk factors, were more likely to have a positive test, whether it was stress or CT, than non-diabetics. and had worse outcomes. This is no surprise, but actually hadn't been evaluated in a stable chest pain population before, but all stuff that we expected to see. What we didn't expect to see was that there was a CV death and MI benefit with a 63% reduction in CV death and MI in diabetics who had CTs as opposed to diabetics who had stress tests. This was a dramatic reduction. We did not see that in the non-diabetic population. So how have these changed guidelines, and how might they change our guidelines and the European guidelines, which are likely to come out this fall with new revisions, the ESC coincident with the ESC meeting, and the ACC-AHA coincidence with the AHA meeting. So in the UK, a couple of years ago, they actually, as I've told you, put CT as the first test. And in the initial test in patients with typical angina, without known CAD, CT for all. If you have somebody with known coronary disease or has had an intervention, then they recommend functional testing. They also have a medical technology guidance for FFR-CT, which was, again, an economic decision that the country would save $11 million a year on its chest pain evaluations if it did FFR, if it added the FFR information to the CT. And this is an innovation technology payment associated with FFR-CT. In Japan, they've basically stopped doing stress tests. It's very hard to find a care pathway in Japan that is anything other than CT. Again, as I've said, so here's my stay tuned for 2020. I think it's likely that in both the European guidelines and the American guidelines that CT will be elevated to class 1 with a level of evidence A because of PROMISE and Scott Hart and other trials. And this is a disclaimer, I'm not on the writing committee and I am not a peer reviewer of this document, so I have not seen it. This is my best crystal ball. I think that exercise ECG will be downgraded out of the class 1 spot. Particularly because of Scott Hart, which was a well-performed randomized trial that showed it did not fare well. I think it's less clear what's going to happen to stress echo, stress nuclear, and stress MR, the imaging stress modalities. Will they stay at 2A? Would be my guess, but I think it's a little bit less clear where those are going to go, or whether we will have, as the European guidelines have right now, dual class 1s for CT and stress imaging. So I think that's really the question, and that's why I can't tell you what's going to happen in 2020. So the third question, will FFR make CT better? And the left-hand panel is data from FAME. It's invasive FFR data, and this is the cut point of 0.8. And you can see even in those with 70 to 90% lesions, there's a whole host of patients who do not have pressure drops across their lesions, so not hemodynamically significant lesions. And if you stent these people, they do worse than if you leave them alone. So very powerful information that invasive flow reserve is very helpful in guiding care, particularly interventions. And HeartFlow has come up with this is basically a big data artificial intelligence application with finite element modeling of the coronary bed from routine CT images. And they're working on a hierarchy of evidence. They've solved the technical and accuracy things and some real-world validation that has come out in the last year that I'll show you, and then I'll talk about a randomized trial that's just getting underway. So the platform study Rick mentioned, this was actually an observational study of people who had a CT FFR on the way to the cath lab versus those who went directly to the cath lab, so a drive-by CT, if you will. Canceled 61% of caths. The rate of finding obstructive disease went from 27% to 69%, and the rate of catheterization without obstructive disease, so nothing actionable at the cath, fell from 73 to 12%. And the graphic here shows you these are the patients who had obstructive disease. It was 27% in both groups, but those without fell from 73% to 12%. Because this 61% had their caths canceled. No impact on safety, and not surprisingly, cost savings, about $3,000 a patient, so pretty powerful stuff. PRECISE is a new trial that I have the honor of leading that is being funded by HeartFlow, And we are going to attempt to address all three of the knowledge gaps that I've laid out for you today: patient selection, test selection, and the role of FFRCT. This is a prospective, pragmatic, randomized clinical trial, 2,100 patients, looking at different ways of evaluating initially diagnostics for stable chest pain. We're going to take the usual care arm, will be stress testing or direct to cath, whatever is the usual arm. The precision evaluation arm will use our PROMIS risk score to assign 20% of those patients to a no immediate testing strategy with optimal medical care, and the rest will be assigned to CT with selective FFRCT if there's an intermediate lesion. So our assessments, our primary endpoint will be at 1 year, an effective chest pain evaluation, both MACE plus cath without significant stenosis or significant hemodynamic information. This is sticking. That's our trial diagram that I've just run through for you. The usual care will have a range of risk. In the precision evaluation arm, our 20% will have no immediate testing. We do expect some crossovers. Patients who have chest pain are not well controlled or don't manage the optimal medical therapy will cross over to CT plus FFRCT. And of course, there's a host of secondary endpoints as well. So thank you very much.